Hello, good morning, everybody, and welcome. My name is Ken Burns. I'm here from Spark Conferences. We are a Canadian healthcare event production company. We produce our own peer-led conferences for a wide array of roles and topics within the Canadian healthcare industry. Healthcare data has an important role to play in supporting Canadian health innovation, but doing that well requires the right governance, safeguards, and level of confidence from institutions. In today's session, we'll explore how organizations can approach responsible health data sharing, how frameworks like INOVAIT are helping institutions move forward with more confidence, and how this work can help unlock practical innovation with real value for patient care and clinical practice. Before we get started, a few quick points on this format. During the presentation, please feel free to add comments to the chat and use the Q&A feature to add your questions for our presenter. If you aren't seeing the Q&A function, check for it under the More button along the bottom of this window. Marjorie will be reading your questions out after the presentation. If you have any technical questions, feel free to send me a direct message for assistance. A recording of this webinar will be provided to you by email and will be available to view for anyone that missed it. And lastly, if you are interested in more case studies and strategies like this, along with networking opportunities, check out the National Healthcare Business Development Conference next month on May 7th and May 8th. Now, I'd like to introduce our speaker. Phil Boyer is a longtime supporter of health innovation in Canada through roles in commercialization and healthcare research. He leads the Health Data Innovation Program at INOVAIT, Canada's image-guided therapy and artificial intelligence network. He is also the lead author of Data Mobilization, Principles for Safely and Ethically Harnessing Canadian Health Data to Unlock Innovation, Economic Growth, and Better Patient Care. Phil is also the chair of Networked Health Ontario, and he holds a PhD in biomedical engineering focused on AI in healthcare from the University of Toronto and Sunnybrook Research Institute. Now, without further ado, over to you, Phil.
All right, thanks, Ken. Thanks for the introduction as well. And thanks for having me back. I presented last year at the Spark conferences. It must have been reasonable enough, as I was saying, to invite me again. For those that didn't see the one last time, this will be completely new content, so I think it should be interesting. So what are we going to be talking about today? So the current state, I want to get specifically, I think, into the social license question, but I'll get a little bit into the background of why this is an issue. Governance and solution using Sunnybrook as a case study, and then talk a little bit about policy, regulation, and legislation, but just so you're not at risk of your eyes glazing over, it'll be about half the length of the other pieces, but I'm a bit of a nerd on this kind of thing, so I had to put it in, and then a bit of a summary. So these are my own opinions, my own reflections, my own musings. Use this with your best judgment, and if you apply it, I am not responsible for for whatever you do in your own domains. INOVAIT, for those that don't know, is Canada's image-guided therapy and artificial intelligence network. We have members across Canada, both image-guided therapy companies and academic institutions, and it's really supporting these image-guided therapy and AI projects, really around the commercialization side of it. So we have a funding program, non-dilutive funding program. We have our MedVentions training program, which is kind of like Stanford Biodesign, for those that are familiar for Canada. We do networking events. And we also have a data program, which is me. So we're hosted by Sunnybrook Research Institute and supported by the Government of Canada Strategic Response Fund. So thank you very much for that. So all sorts of different companies and technologies are represented in the INOVAIT network. So things like planning for eye surgeries, personalized cardiovascular care, rapid optical pathology, tissue imaging, all sorts of different things. And so in terms of imaging modalities, it's like ultrasound, CT, MRI, optical, X-ray. So it really kind of runs the gamut. And then we see that these technologies are really revolutionizing healthcare, and they're already starting to be adopted in Canadian healthcare and affecting Canadian patients. So we want to support these. Probably many people have heard this before, but just to recap, Canadian data is very valuable. And it's really the secret sauce of these combination of factors that we have here. We have a publicly funded healthcare system, so we have these large-scale data sets that exist in public institutions, high diversity of patient demographics, and a high income population as well. And so the result of this is very, very helpful for specifically for AI and medtech, because they can train things once. It's more generalizable to other populations. They don't need to retrain in new settings, so it means much less development costs and reduced time and application to other settings as well. So there are significant incentives to leverage this data for medtech and for other reasons, which is very exciting. We have this resource that can be leveraged in Canada, but it's also very worrying, right? There's conflict of interest. There's all these concerns about misuse of this data, so we need to manage this as well. And I will say on this slide, since we're on this slide, a little bit of a public service announcement here. Yes, your data is valuable, but if you're sharing data with a startup, especially a Canadian one, and their innovation may benefit specifically your patients, and this is why you want to do this, probably you want to look at it from that angle rather than maximizing, the funds and returns in exchange for your data, though there could be like some revenue extreme or whatever out of it, right? But really you want to benefit the patients and advance your mission of your institution, and it should be looking at it from that direction. So health innovations, data frustration. So this is many of these quotes I presented last year, but the result of companies not being able to get access to data from Canadian healthcare institutions, essentially they spend months to years trying to get access to Canada. They waste hundreds of thousands, sometimes the equivalent of millions of dollars in delays just trying to get access. And if you're talking about startup companies, they have defined runways, right? They may only have a few months. And so what happens, how does this affect the success of these commercial entities, these startups, when you're delaying their technology development by months or even years at a time? So what ends up happening is many of them just go outside, they give up, they go outside the country, they go to the United States. And I think this new quote that we heard from a company a couple months ago encapsulates this. We would be dead if we hadn't been able to get data from the States. And so these are technologies that are essentially created usually in academic centers or research centers, clinical centers in Canada. They're being created through fundamental research that's supported by Canadian taxpayer money, but they're having to leave in order to get their data, in order to develop their technologies. So there's less opportunity for collaboration here. We lose economic development opportunities. And there's lots of opportunities to adopt these essential technologies into healthcare as well, which does a disservice, I think, to our patients. So I apologize for those who haven't seen the John Wick movies, but I couldn't resist. So is privacy risk stopping you from sharing your data? So, privacy commissioners, for some reason, many institutions seem to envision them as some kind of righteous entity, like these boogeymen or women, or even the Baba Yaga or John Wick or something. If you put a step out of line, they're going to swoop down and they're going to crack the whip. That's not really the case. If you actually listen to their public presentations, they're in support of sharing data for innovation. The key is in doing so responsibly. So in general, let me just minimize that. In general, privacy legislation in Canada is actually fairly permissive if you de-identify it, right? So in my opinion, and the opinion of many others, if a custodian is unwilling to share data for innovation, that's their rule, right? It's probably not due to privacy risk. It's probably concerns about reputational risk. So why is that? So speaking of privacy commissioners, we can use some of the examples and complaints to Ontario, and I'm sure we see this in other provinces as well. So PHIPA decision 175 is a good example of this. So this is a case of clinics essentially de-identified data. They were selling that to data brokers, and there was a complaint, and the privacy commissioner went through the process. And so I'm not a lawyer, but I will summarize this by saying ultimately this wasn't afoul of the law. They de-identified the data well. And so there's really more about the transparency piece, are informing patients that this happening. And so if we look at the quote here from Patricia Cossine, the Privacy Commissioner of Ontario, on this case from, I believe, their blog, while the focus of PHIPA decision 175 is on compliance with PHIPA as it existed at the time of the investigation, the broader ethical questions inherent in selling or disclosing even properly de-identified personal health information are ripe for public debate. So translating that is really saying, well, we're weighing in on the law, we're not weighing in on the ethics of this. We're not saying whether this is, morally right or not, or whether it's according to the public good, right? That we're just weighing in on the law. And so this brings me to this article on the left, and this came out around the same time, maybe even the same day, as last year's Spark conference. There was a journal article that came out saying essentially a private company had bought a chain of primary care clinics. They were using the data, and they weren't sharing it externally, essentially to identify candidates for drugs on behalf of their pharma company partners. And if you look at the original journal article, there's some rationalizations for this saying, patients can benefit from these drugs, so we want to be able to identify them. So my issue with this, and the issue of many others, is that the uproar that happened, the panic that happened because of this, did so much damage to public trust and social license for use of data that no matter what kind of benefit to these, patient population at this local point, this essentially encourages even more clamping down of sharing of health data with the private sector, especially to support innovation in Canada. So one of our responses on INOVAIT was to submit a letter to the editor, which was published, basically saying this is in contradiction to our principles for safe, ethical, and trustworthy Canadian health data licensing, and we should be using this data to support innovation in a responsible way for the public good. The problem is that orders of magnitude more people read the original article than they did this letter to the editor, so the damage is pretty much done. So talking about social license, the next 3 slides will be around that. So Canada Health InfoWay did some research a couple of years ago, and they did a public survey, and I want to hone in on a couple different questions that they asked or statements saying, as a member of the public, do you agree or strongly or disagree or what have you? And one of those statements is, I am comfortable with AI being used in healthcare, and it's around 28% agreed, which is not high. And I am knowledgeable about how AI is used in healthcare, and it's even lower. It's about 25%. So if you're a healthcare institution or you're a Canadian company developing AI in healthcare, this is concerning, right? Because you want to be able to adopt these in order to benefit your patients. So this is some research done by the Privacy Commissioner of Alberta. They asked some questions like, what do you think about the use of health information to train AI for creation of commercial AI products in particular? And it's around 19%, so not high, right? But I think this part is really interesting on the data breaches question. If we compare between the concern around data breaches around banking and financial information and health information, it's higher on banking and financial information. And which is very interesting because these are both, sensitive pieces of data, but nobody wants to be, the victim of fraud, right? But banking, we have TAP we used to go in to buy groceries and using TAP with our credit cards, sharing data instantaneously, Interact, like all these things are based on this trust that we're putting into these companies. And if this doesn't work, then it's immediate. We know people get upset, right? And it's very different in healthcare. If your primary care doctor, your family doctor, if they're still using faxes, then like why do I care about this, right? That's happening in the background. The problem is if you go in an emergency room and they don't have your information and they don't know how to treat you because they don't know what medications you're on. And this is what we're seeing in healthcare right now. And unless you're engaged in the system and you're actually experiencing these harms, you just don't know. And that's part of the problem with social license for healthcare data. So last thing on social license. So HDRN did this research, examples that are not within social license. So it is not within social license for someone or some organization to sell or resell someone else's identified use for a purpose that has no patient, public, or societal benefit. So you notice the difference here. This indicates that whether it's de-identified or not, people still want the health data that's being collected through the healthcare system to be used for patient, public, or societal benefit, right? This is being supported through public money. This is their data. Literally, this is the public data, and they want it to be used for good reasons. Examples that could be within social license, the participants discussed, but did not agree that it could be within social license for health data to be used for public companies. So it could be, but like, who makes that decision, right? So we're in this kind of catch-22 right now, where the public has not a high understanding of what the benefits of AI could be in healthcare, and even how sharing of data could support the creation of these technologies. But in order to demonstrate the benefit of these technologies and the value of them, we don't have the data. Like, these companies do not have the data to create these technologies. So right now, I think, based the fact that we may not have that social license, we shouldn't be depending on some kind of future large-scale literacy initiative to change the culture in Canada. We have to operate within right now what the social license that we do have. Because if we do this right, if we do this responsibly, social license will increase because we can demonstrate the value of these technologies in healthcare. And that, to me, means principle-based decision-making, assessing on a case-by-case basis, which I'll talk about, and most importantly, involving patients and community members in decision-making, so you can ask them directly, are you okay with the specific case of this data sharing that's being proposed? So I'm not going to go too much into the de-identification piece, but this is all just to say, yes, you may be de-identifying data, but who's ensuring it's being used for public good? What kind of oversight is there? Is there sufficient transparency? And I do question myself, and we see this in some of the articles that have come out, like the one in the Globe and Mail. Does the public fully appreciate the difference between de-identified data and identifiable data, right? And I think this impacts how you would use it and the protection you put in front of even de-identified data to ensure it's being used for the public good. And again, we come back to a quote from Patricia Kassam: even in good hands and for appropriate purposes, the sale or disclosure of de-identified data without clear and meaningful transparency can seriously undermine public trust. I wanted to talk just a second about privacy-preserving technologies, because this is often quoted as kind of the future about how we deal with privacy harms. And so these are very important. Federated learning, synthetic data, the research into this, these should still be rolled out. The issue right now is that if we say we're only going to share data under these specific circumstances when we have these in place, that means that most data sharing can't happen in Canada. And this is what we've seen. So we aren't supporting these technologies that can benefit healthcare right now. And I did drop in on the synthetic data piece because I thought this was interesting. This estimate saying that synthetic data in the US will be worth about $3.67 billion, which is a large number, but I don't think anybody thinks that this is the scale of value of all of the de-identified health data in the United States in 2031, right? So there's many other reasons why we should protect de-identified data and also leverage it as well. But regardless, we're now very good at addressing privacy risks from health data, but what about the risks of other harms? And so this is where the networked health harm framework comes in. So I'll talk a little bit about networked health later on as well, but we've become very good at protecting privacy, and we focused on that, but we're not very good at dealing and managing these other risks of harms, like failure to use data for the public good, damage to the workforce because we're not sharing data, and what does that do to mental health, for example, of our custodians and practitioners? And we're not adequately supporting Canadian innovation that can be used to benefit patients. So let's get into the meat of governance solution that we put in place at Sunnybrook. I shared this last year. This is part of INOVAIT's data mobilization framework. I'm not going to go into the detail of each of these principles. I would suggest you go into our website. It's in the report section. You can download it and look at it there. But we'll go into how these have been operationalized at Sunnybrook. So where we are on the timeline. So the previous conference, which is about May 2025, we had the concept of the Data Access Committee created. We had some tools and processes that were in draft, and we started recruiting for the committee. And really around that presentation, I talked about kind of theoretical cases of data sharing. So right now where we're at is like we have some experiences that I think we can share now. And so in the design of these, so we had a kickoff meeting that happened in July 2025. I explained like this is the data mobilization framework. This is why we should be sharing just a level set with the group, sharing data for innovation, de-identify data, and this is how we're going to do it responsibly. These are the tools that we're going to use. We've had the opportunity to assess quite a few requests now and refine these tools and processes, which I'll explain in a bit, but also very importantly to answer some of these key institutional questions. What are we concerned about? How do we address them? And set some precedents around how do you engage in these types of data sharing for innovation? And also the questions about how do we integrate this into existing institutional processes, which I'll talk about in a bit. And all of that was put in place. We now have signed our first agreement, and I hope for Sunnybrook folks that are watching, like first agreement. Well, we went through all of that just to have one agreement, but we really don't want to minimize the effort that was done in order to get to this point that you would have had to go through too at your own institutions in order to have a streamlined process. But now we can share this with you. We can share you the tools so it won't take you this long. Data Access Committee. So this is kind of the constituency. We have community partners and patient partners involved. Indigenous community partner. We have legal and privacy from the risk plans. We also have an ethicist on it, even though this is not the REB, because we want to be able to evaluate these requests from an ethical perspective. We have clinicians and researchers, information security, and we have definitely seen while going through these that questions and issues have arisen that would not have otherwise, and solutions. And that is really the benefit of having this group of people together to be able to talk through considerations and concerns. And it was explicitly adopting INOVAIT's data mobilization principles. And you always want to look back at how does it advance the mission, vision, and values of the institution. So take a step back. What is the kind of typical scenario for technology development? So let's imagine a med tech company, maybe they need imaging data, they're developing some kind of treatment, but this is not a research study. They're not proposing partnering with a PI at the institution. They're literally going to take the data and they're going to develop a commercial product out of it. So the first question that comes up is this research? And this is an important question, right? Because if it's research, then REB comes into play. There's all these requirements around in legislation about research data sharing. And it's not really that clarified. And these are conversations that I've had across the country over the past several months and even the past year. But it seems where most people are landing on, and this is not research. This is literally just using data to develop technology. But then that begs the question, if it's not research, then who's responsible for oversight of this? And so that's where the DAC comes in. And I really don't want to minimize the role of the REB, but we also want to make sure that we have something in place for oversight of these data sharing activities that might be outside of the scope of this, but also cases where commercialization is happening of the data. So we have specialized expertise that I've talked about, but you can also bring in a larger scope of assessment that maybe wouldn't ordinarily be evaluated on the REB side, like assessing institutional resources and capacity to engage in like the data collection, for example, or if this is going to be deployed in a healthcare setting, like how it would integrate into workflow. You can even look at things like data sovereignty or leverage the environmental knowledge of different members of the group in the business folks. They can do due diligence on these companies to make sure the data is being safe, shared safely and securely. And maybe one of the most important things is bargaining power. The institution, the data holder, they can negotiate. So they can negotiate to capture the benefits that may not ordinarily even be considered in a typical data sharing agreement. For example, they may say, well, this data is being shared with the company. Well, they're going to put a lot of effort into potentially cleaning this data. That will increase the value of the data. That can be shared back with the institution. We can leverage that for our own researchers or research agreements, or even for future commercialization activities. you can insist on having technology that's developed from it deployed at your own institution to develop to be used with your own patients, right? So you can actually see the benefit of sharing that data locally. And of course, a revenue stream if you're talking about licensing. Healthcare institutions, they require funding to operate, right? And even though they're not for profit in Canada, we sometimes forget that. So that funding can be used for future research. It could be used to benefit the operations of the hospital, and that directly benefits patients. So some of the design considerations around, what falls under this Data Access Committee's oversight. You want to think about like what kind of data? Are we talking about research? Are we talking about like clinical data? Are we talking about both? In our case, it is both. Is data just being shared externally? Is that all it's going to look at? Or do we want to look at the external access part? We're just looking at the external piece. Just requests for companies, or does other things? And I'll get into that in a second. But what about clinical trials? Data is being shared with companies for years, and this is big business, not only in Canada but in North America. And it also benefits patients because they have first crack at getting access to drugs that could benefit them, benefit their care. You really don't want to get, I'll caution you, you don't want to even be considered to get in the way of clinical trials like this, right? So you have to design and make very clear in your processes how you take this into account. How will this operate alongside other oversight? For example, we have an AI committee. Some individuals may sit on both. So you want to define clear responsibilities and differentiation between the work of the two, and also have a constant line of communication. So you're not duplicating work, but you're also understanding, well, if it comes into this group, what is this group looking at? Do we need to flag it to each other for certain things? And also I recommend parallel reviews. Of course, it depends on your own governance processes. But if you put this in a serial way, saying, oh, REB needs to sign off, then the AI committee needs to sign off, then the DAC, then you're just slowing things down, right? Whereas all these things can be done at the same time. And again, this is one of the concerns that you often hear is, we have one more level of oversight. This is going to become a barrier. This is going to slow things down even more, and PIs will get concerned. So you want to reassure people at the institution. And then one other question, who's going to support the activities of the committee? So you need a team that's responsible for doing this. In our case, it's the Tech Transfer Office. Exclusion criteria, so no data is being excused. So if it's any of these blue squares, it doesn't need to be seen by the DAC. No data shared externally, then it doesn't need to be seen. Quality improvement is a different process, and quality improvement is generally handled a little bit differently in legislation anyways. Industry-initiated clinical studies, I think you just need to have a strong definition of what that is. And academic purpose with no commercial use in REB. So you want to reserve the time of this essential panel of experts for cases that are actually worth their time. Maybe they're high risk, maybe there's like this commercialization piece, and you don't want to waste it on these kind of typical researcher to researcher standard research studies that we see. Principles and terms of reference. So this is intentionally incorporated into it. So the committee shall adopt a balanced approach, so balance the risks and the opportunities. But you notice here I said reducing risk to an acceptable level. And oftentimes you see risk mitigation, you use those terms, or minimization. And where that becomes a problem is if you minimize risks, you can always minimize risk to zero by not sharing data at all. And this has been the position that's been taken by many healthcare institutions in Canada. And we're missing out on all these other opportunities. So we really need kind of this balanced risk-benefit opportunity. And building this into your terms of reference, I think, helps set the culture and the expectation around that. Second point, don't reinvent tools, don't reinvent processes. And the third piece, proportional risk assessments, proportional evaluations. If it's low risk, if it's small opportunity, don't spend as much time on these. Okay, so we have this tool available now through INOVAIT, the Data Request Evaluation Scorecard. And essentially what this is, and you can download this online or put in a request of this. This comes directly to me. You can put a request for this, and this is a little snippet of the tool, and this is being used to evaluate at Sunnybrook right now, these kind of risk benefits evaluations, but also includes this instructions for use, which is kind of I think it's minimized. Really, this is an instruction manual for setting up a committee. setting up this kind of governance at an institution. So you can get access to this through a non-exclusive licensing agreement for us, and I put asterisk free because I'll explain that in a second. So there's a couple of reasons why we're using a non-exclusive licensing agreement. So the first is we want, if you're using this, if you change it for your own purposes, we want you to share this back because we want to be able to share the learnings that you have with the rest of the community and develop this best practice, which brings me to the second point. We want to know who's doing this. We want to know who's engaging in this kind of activity at different healthcare institutions so we can create this community of best practice around this topic, because the problem that we've had to date is people aren't talking about this publicly and they're not sharing information. And I think there's an opportunity here that we can all get together and talk through this. And the third reason is that if you're a service provider and you want to actually monetize this tool, like as part of your services, that'll be a separate agreement. So we'll talk about that if that comes up. So DAC review process. A couple of points here that I want to talk about. First is we have a delegated review and a full committee review, kind of like an RUB. We split this into different teams. So patients and community members, they need to have their own teams. They might have the same rows in the scorecard, but they have different issues that are important to them, right? Each team fills out their own portions and they're returned. And then they give preliminary votes as well. And I'll talk a little bit about why that's important based on experience. That's sent back to the TIC transfer office, who consolidates this and then sends it back to the committee for review. And there's this formal voting process, approve, or if there's recommendations, or if it needs to come back or decline, etc. So I'll talk about the formal voting process first and why that's formal voting is important is because, you tend to have certain individuals that are just more outspoken, and it risks, as we've seen and experienced, other people not putting their hands up and say, well, I have a concern, right? That may not have been addressed, and they may not just raise their hand and say, okay, this is still an issue with me, but I don't want to rock the boat, right? So they'll just vote along with what other people are saying. And this gets back to the preliminary votes too. Preliminary votes gives you the opportunity to say, okay, this is your vote previously in your preliminary from the offline review. Is this still the case now? Has your opinion changed? And so this formalizes it so you can address these considerations. Last thing I'll talk about, because I'm just looking at time as well, is transparency in practice. Last thing I'll talk about in this section anyways. Most important thing you can do is be transparent about your activities when it comes to sharing data for innovation, even de-identified data. So you can look at our framework, the data mobilization framework. It gives suggestions about how to operationalize this and what the important pieces are. But even de-identified data, even though it may be legal to share it without patient consent, according to PHIPAA and OIPC Decision 175, de-identification is still technically a use of data. So patients must be notified that it's being performed. So what does notification mean? In PHIPAA, where it's likely to come to the individual's attention or provides the individual with such a notice. Practically speaking, this is probably a website. You may think about incorporating this into your informed consent, and even posting your privacy principles where folks can see your privacy policy. So last thing in this section, web page co-development, again on the transparency piece, it is so essential that you bring patients into the loop on this and get their feedback and develop this with them, because no matter what you think, you're not going to know what matters to patients. And they will identify what matters to them. So here's some of the lessons that we've learned having gone through this process, one of which is limiting how data is shared. For example, not using it and saying this publicly on a website. You're not going to use it to exploit people, manipulate people, share it with insurance, or use it for anything like targeted marketing. You're signing off of these terms. People are used to this, signing off terms and conditions in your apps or whatever, and then being marketed for products. Healthcare institutions should not be doing that, not even with de-identified data, even on aggregate. Stating with personal information will only be shared with consent. This differentiation of licensing versus selling. So selling being essentially, well, we've sold the data to a data broker. We have no more control over it. They can use what they want. They can resell it if they want. Whereas licensing gives you the opportunity to put in requirements around saying, well, you can only use it for this, and you have to come back to the institution if you're going to do anything else with it, contractual controls around sub-licensing, re-identification, things like that. So all these protections that you might not have with just selling the data. And then plain accessible language. And the reason why I mention this in particular in this case is because you not only have to use plain and accessible language, what you say still has to be legally accurate according to your privacy legislation, right? So you have to find that balance there, which is trickier than you might think. Other tips, framing this is from the perspective of data partnerships, you supporting innovation in Canada. And that should be the culture that you should develop as the institution. This is not just about making money, right? What data is being shared? What even is data? What's the difference between de-identified data? Tying it back to the mission and vision of the institution, and then being very, very clear for patients, like, why are we doing this? What are the benefits to patients, to society, and to the public good of Canadians? Okay, policy and legislation piece. This is my part. I'm really interested in talking about this again. So collective impact. These are some trends, I would say, these slides that we've been seeing. Collective impact is one of them. Essentially, the idea is that there's a community of people that get together. They kind of take off their organizational hat, and they're doing this they're all marching along the similar direction because they have a vision of where we want to get to. Networked health is one example. I'm part of that, and all these other groups here. The only reason I'm in the middle of this is because this is an INOVAIT event, but this has really started in Alberta with Ewan Affleck and Terry Price, has since expanded to BC and Ontario. So I'm the chair in Ontario with Ann Forsyth, who's not pictured. But some of the outputs of this is we had our Renew 72 campaign, Bill C-72, the Connected Care for Canadians Act, to support interoperability of data, which was very, as we're told, influential, as we've been told, in getting this reintroduced as it has been now as S5 in the Senate. There was consensus statement from regulators that just came out recently through Networked Health in Alberta, saying how important data is to them, and all these previous releases, and there's going to be more coming soon, very shortly, from Networked Health dealing with some important topics. And one of those topics, and I'm not expecting you to read this, these are going to be shared afterwards, but the Pan-Canadian Health Data Charter originally actually came out of the Alberta Networked Health Group's work, basically moving away from this custodianship model in healthcare that we have, where data is protected, minimize the risks of privacy harms, but not maximizing the benefits that would be used for other things, to more of this kind of stewardship approach where we want to capture the balance benefits for the benefit of patients and the public in Canada. And I think the data stewardship program of CIHI, they're doing good work. I want to point out to them, like, they actually just released a framework that you can evaluate, self-evaluate as an institution, your own data stewardship maturity model. So you can take a look at their website for that. We're in a period of legislative change. So I talked about Bill C-72. That's essentially now Bill S5. This is targeted towards health information technology vendors and prohibit data blocking. Data blocking essentially means any activity that prevents the sharing of information from the vendor's technology, and usually this is done intentionally. So that sets up the opportunity for future regulations, including around data standards. So this is currently making its way through the Senate. The Senate meetings on this, the committee meetings are actually starting this afternoon. If you want to tune in, I'll actually be at the Senate committee meeting next Thursday, to talk about the MedTech perspective on this. We're also seeing modernization of provincial legislation as well. So Bill 3 in Quebec, for example, setting up these research access centers, which is very, in some ways similar to what we've seen with the European Health Data Space, which I'll talk about. And then Bill 11 in Alberta, Bill 194, talking about public use of AI. So period of legislation change right now because of AI, because of this recognition of how important data is, not just for healthcare, but also for innovation and supporting AI. Couple more slides. International inspiration, European Health Data Space. I'm not going to get into this in detail for the purposes of time, But the purpose of this is essentially this is EU-wide regulation, empower patients greater access control of their data, and make it accessible for research and innovation. They have these health data access bodies that are being spun up in each region to govern secondary use of data. Identifiable data will be accessed through secure processing environments, whereas data users will only be able to download non-personal electronic health data from the secure processing environment. So we can learn some things from this. One of the first is that this is an example of a governance framework that's been adopted in a federated system. There are countries over there. We have provinces and territories, which are their own jurisdictions. We should be able to do something similar. Obviously, we have different challenges here, but I think we can use this as an example. Common data standard adoption. They're still allowing data sharing for de-identified data, but it's appropriately governed, and then prohibitions on data use as well. So last major slide of content is this TEFCA out of the United States, which I think is very interesting. The Trusted Exchange Framework and Common Agreement. And all of this has implications on data sharing for innovation and will impact you in the future. This came out of the 21st Century Cures Act, and essentially TEFCA was a result. So there's a network of network models. So you have these networks of health information data sharing, sometimes like their vendors like Oracle or Epic. Oracle is the most recent one, which is why it's mentioned here, but often it's custodians as well. And essentially it connects them all together. Everyone has an agreement saying we're all going to abide by similar principles. We're all going to abide by common standards, all kinds of standard operating procedures to support interoperability between these network of networks. And so you could see something like this being implemented here, potentially, via Bill S5 through regulation. So these are some of the things we think we should be looking at. Last piece, data sovereignty, big topic. Everybody's thinking about it. And this is just to say that as we're thinking about putting in the infrastructure, we should also be thinking about how do we ensure that when we do want to share data, that it's in the best interest and public good of Canadians. And an honorable mention to this sovereignty score from the Canadian Shield Institute. You can look at it now, and you can use that to evaluate your how your own policies, advance or benefit sovereignty in Canada. So last two slides. So INOVAIT's data program, where are we going with this? So in the short term, for data, we're going to update the toolkit. We're going to have request tracking sheets, standard terms and conditions for data transfer agreements. People have asked for this. Looking at a data governance policy, whatever else you think and we think might be useful. I'm happy to take ideas on this. More knowledge translation, so white papers, reports, hosting events around this, and focused meetings and groups around particular topics towards developing that community of best practice. And new initiatives, and I'm staying a little bit hush-hush on this, but directly equipping healthcare institutions with the tools, resources, and frameworks to engage in responsible innovation data sharing. So stay tuned for that one. So if you don't remember anything else about this presentation, Canadian health data is exceptionally valuable for medtech AI development, but currently reputational concerns over social license and public trust are inhibiting health technology innovation. But we need to demonstrate the value of AI in healthcare in order to gain that social license. That's my belief. Transparent and inclusive governance frameworks. We have some tools that you can use in order to develop it yourself. And legislative action and policy are moving forward to set the foundation to exchange data and do that in a responsible way for innovation. So I think I'm right on time. Folks are welcome to connect with me through LinkedIn, follow INOVAIT along, and I think we have about 15 minutes left for questions or so. So I'm happy to take those.
Thank you. Thank you so much, Philip. Hello, everyone. Thank you so much for joining us. Your presentation, Philip, was wonderful. It showed us a lot about data sharing within innovation and how to navigate some of those challenges. And we're going to have some questions that will discuss those challenges, because I'm sure several people at their organizations are experiencing some of those challenges you noted in your presentation as well. Let's start with this first question. And, across many of the conferences that I've been at so far in healthcare through different sectors, they mentioned you need to work with the community. So with data sharing, right?
Mhm.
What about patient consent? How do you build that trust between the patient and needing to collect their data?
Yeah, so I mean this is part of it, right? I mean, even in legislation, you can't be collecting data without consent, anyways. But what we're talking about here is mostly around the sharing of de-identified data, and so legally, at least in terms of HIPAA, it like differs by jurisdiction, especially in Quebec. If you de-identify data, you don't actually need consent to share it, but you do need, there are some notification requirements. But there are some situations where, even though you may not legally need it, it's still a good idea to get patient consent. And you should build that into your processes anyways. Part of the issue here, and part of what we're seeing, the conversations seem to be shifting a little bit around consent in these conferences that we see is, how do we address the fact that like so much of this data has already been collected? It could be used for innovation. It's not feasible in order to retroactively get consent. The other issue is that, are people even aware of what they're consenting to? People are used to just checking off on things, right? So is that a good practice of just saying, and this is what we've seen so far, oh, it's consent, we're kind of legally had permission to do this, now we're good to go with whatever we want to do. And that brings me to the point that you're asking about is community involvement and patient involvement. It is so important to having patients engaged, even in this kind of micro level about assessing when data should be shared or not, because patients often don't even know what they're consenting to. They don't know what kind of protections are in place, right? So you need to have that
Right.
other layer of protection in place so you can make those decisions and ensure that you're doing this for the public good. So, I mean, there are discussions like in Europe and elsewhere where they're putting together sort of governance mechanisms that ensuring that data is used for the public good, not necessarily in the case of consent for de-identified data, but there are still some
Okay.
cases that you'd want it anyways.
So you're saying it's a matter of communication and
Communication,
making them
communication, but
aware of
engagement as well.
engagement. Okay, okay. Very interesting. Because from a marketer's background, we collect data, as you said, but not for
Mhm.
the purpose of the better good, but to do my job. So I understand. But in a sense, it is for the better good, right? For some products, but
Yeah,
very interesting
can I say
perspective.
something on that just quickly? So the who decides what's better good or not, right? And that's why you need to have
Right,
patients involved because the
right.
business development department of your healthcare institution is going to have a different idea, right? So you always kind
Mhm.
of need to come back to that community involvement in those decisions.
That's a really good perspective. Thank you. I
Mhm.
appreciate that because BD is probably aligning more with what our intention would be. Finding that balance between, I guess, finding ways to fund an
Yeah, and
organization,
like that, and again, like that, the funding is important to hospitals as well. So.
of course. Well, thank you, those who have added questions to the chat. If there are any other questions, feel free to continue adding them into the Q&A box. So, Philip, here's one question on the board. How long do committee reviews for data sharing take? Will this become a major bottleneck if data sharing becomes more widely practiced?
Right. So what we've seen, and I actually didn't mention this, is that at the beginning, you want to be very conscious if you roll out something like this data access committee, that you're not just, have a giant funnel of every kind of data access opportunity of the institution, because it will become a bottleneck. And you need to address those particular questions, those institutional questions in order to do this. So you want to start them probably with some easy questions to start and start like developing some precedents based on what the answer to those questions are. As you go forward, more of these don't need to be seen by the committee. They can be seen by kind of the delegated committee, which is a smaller group of people. It doesn't need this kind of sharing it with all these, sharing the scorecard and the briefs with all the different teams, which takes like 6 weeks. It's a 6 week process if you have a full committee, just based on the fact that there's this back and forth. But now we're at the point that most of them aren't going through the full committee. They could just be looked at and say, no, well, this is what the committee would say based on previous precedent. And it doesn't become that bottleneck. But especially at the beginning, you just need to be very aware of not bogging down and like overwhelming the committee with everything at once. Did that answer the
Okay.
question?
I think it does. So how do you know what to prioritize?
So that is a very good question. Some of this will depend on what the scale of the opportunity is, right? So it can't just be like the first. So eventually it'll get to that point where like the first, as they come in, they'll be looked at and it'll be like this kind of revolving door every 6 weeks or even more quickly than that if it's delegated. But if there's high risk opportunities and really timely opportunities, then those are the
Right,
ones, like if they need to be addressed now and it's impacting something, like for example, the
right.
viability of like a large collaboration, then those are going to come first. And other things have to be put on the back burner in those cases.
Okay, okay, thank you. That does answer the question. And especially, how do you prioritize if you do have an overwhelming amount of data that you'd love to share with
Yeah,
committee
yeah, yeah.
for review? Okay, next question. What is the biggest misconception preventing Canadian healthcare institutions from sharing data with private sector innovators?
I love this question. So the biggest misconception is that company, like private sector, is the enemy. There's a
Right,
huge amount of antagonism, especially in healthcare, uh, to and like mistrust. And they think that every company is just inherently unethical, right? It's not the case. Innovation is not innovation is not innovation, or and same thing with industry, right? If you're talking about these companies that are in the Innovate network, like most of these were started by clinicians, right? They're coming out of our academic
right,
institutions. They were doing this because they saw a clinical need and they also want to help patients. Yes, there's a commercialization and business opportunity involved. That doesn't mean they're
right,
unethical people, but there's a huge amount of distrust in this view that just because you have a company, you suddenly become untrustworthy. Whereas the vast majority of people, especially when you're talking about innovators, I'm not talking about these like giant, trillion-dollar companies that are ruling the world, right? Like that's a different
right,
question. We're talking about like domestic innovators developing technologies for Canadian companies. It's a different thing.
right.
And again, like case by case basis, 100%, you need to have patients involved in these discussions.
Of course. And I mean, it speaks back to, like you said, the whole trust in patients. And you had mentioned banking does this, right? How do we,
Mhm.
with clients, how do we easily trust that we can just tap our card, put in our
Yeah.
information seamlessly, because now there's tools that doesn't need us to type it in anymore, right? It's but because we are willing to make the trade for accessibility, making processes simpler, easy. We don't have to look for our cards in our bag. So why
Mhm.
why can't we do that with healthcare? Uh,
Yeah, and so I will add to that saying that people, unless they're involved in health, like clinicians, for example, we hear from so many clinicians, especially with the work that I do with Networked Health, this community group, that they're
right,
seeing this on a daily basis. They can't get access to, like, people are actually dying. There's a statement, like we hear this in conferences sometimes, people are dying with their privacy intact, which is actually the
mm,
state that we're
wow,
in Canada right now.
wow,
Clinicians don't have access to data, but the thing is that people, as I said, are just not aware of it. They're not aware. People think like it is like banking. People expect like, oh well, if I go to my primary care clinic, it's just available wherever else I want in Canada instantaneously. But people are still sending things by fax in
they are,
Canada.
they are,
Everything is very much disconnected. And like the pandemic was a horrible thing, but one of the I guess the silver linings of it is it did bring to light just how disconnected our healthcare system is. And
yes,
because of that, there's much more attention to this and all these things like Bill S5 and all these
yes,
initiatives that we're seeing in order to leverage their data. People are, and like that's why I said like that quote that I said, I really think it's different this time. And I've heard that from many different people. There's an optimism out there right now that this will change, and we're seeing a difference. And part of that's because of this kind of community movement of people that are just fed up. They're frustrated with everything.
right.
So let's all get together and let's solve this and try to push this forward and keep this onto the agenda.
Both those internally and externally within healthcare
Exactly.
patients.
Exactly.
And
We're all dealing
so
with the
yes,
same
we see it.
problems. Yeah, it's all the
We are.
source of these problems are all shared.
This might be a funny question, but with only 5 minutes, um, timeline? Do you see a timeline when everything comes to to its full way that we picture
Oh,
data to be shared and
that's an
innovation?
amazing question. So it's funny because I think I was even mentioning before the call. So INOVAIT hosted an event in Alberta, um, and it's Health Data Connect was the name of it. And we had a person there, like our keynote speaker was from Denmark, and they were talking about all the things that they're able to do with data there. They have like 3 or 4 apps on their phone, and they can see everything about their personal history going back for decades. They have decades worth of data. And it became clear in this room, they're like, oh man, we are decades behind. So, but I don't think it'll take us decades to get there because the technology is there.
Okay.
What's preventing us right now are these cultural issues and people not collaborating or working together. And part of that's the lack of, consistency in legislation and regulation. It's all this kind of like soft things rather than technology. And if you have a Bill S5, for example, that's preventing data blocking, that means that those
Right.
existing institutions and their technologies can now suddenly talk to each other. So you can start seeing that data. So it's not about rebuilding all of our decades worth of legacy infrastructure. It's about connecting what we have and everybody getting on the same page and collaborating and kind of having some kind of strategy around it. And I think we're going to get there. In terms of years, I really don't know. I hope it happens. Like to get to the point like of Denmark, that's like a ways away. But I get to the point where I think I would call it reasonable.
Yes.
That may be in the next few years. Like I see this as a potential happening, but we'll have to go through all those steps to get there, to have
Right.
something like built into regulations and all the provinces have to sign. Like there's all this stuff that needs to be done in the meantime.
Yes. I'm hopeful. I'm not
I'm
in this,
very
but
optimistic about
I
it.
do see a lot of movement. We do have 3 minutes on the board and two questions to go through from the audience.
Sure.
One is what were the biggest barriers encountered when operationalizing, sorry, innovate framework in a real institution?
Yeah. So one of the things is understanding, and I think I touched on it a little bit, is where the processes sit in the institution and making sure that you're not duplicating the work of other committees, and you're not getting in the way of that. So like understanding that, and like literally we have a map. We have a map of saying if a request goes through here, and it's too complicated to show on slides. But if a request goes in
Okay.
here, who does it go to? And then what stage does it get to go through here? So like some kind of process map and like understanding who is and Sunnybrook has like if you include like learners and staff and students, there's like 16,000 people at this institution. It is not small.
Hmm.
There's
Right.
there's absolutely siloing going on, but you need to be able to understand who's doing what. And that's a major undertaking is just understanding what all the data sharing is happening in the institution and like what kind of level is their oversight and all of this because
Okay.
it is so complicated to get your head around.
Okay. Okay. And is this all mapped as you as
Some of
well?
it, in terms of the data
Okay.
access committee, it is. But like, so part of the reason why I'm saying, and you're welcome to invite me back back next year. I can talk about what
We're
we've done
gonna
since
need it,
then
I
in terms
think.
of these other requests. But
Yes.
the part of like this is a work in progress. Like this is going to take time in order to centralize some of these processes and make sure they're all kind of aligned because we want to get to this kind of stewardship approach
Right.
eventually, where everything's being done in like a reasonable. I wouldn't say I would say reasonable, but like efficiency, right? You want to target efficiency, and this is it's so much harder when you have a large institution like ours.
But at least you're getting started because that's what it needs
Yeah.
to
We've
get to
made some
that
good
point,
progress for
right?
sure. Yeah.
Okay, one last question, and I know we're close to time, but we might go a little over everyone. Is there a precedent for data licensing with industry at Sunnybrook? How is the intrinsic value of the data license determined? And I apologize if I mispronounced that word.
Yeah, no, so yeah, like those are the two different questions for sure.
Yes.
So data licensing, I would say, and we see this with many institutions, it hasn't been framed like that. It's really been under the kind of sponsored research piece. REB will sign off on it. If a clinical study will be done, and sometimes we've seen in the past that it's like shoehorned into a clinical study because the company needs the data And they're like, okay, well, in order to get the data, we have to work with a PI and we have to put together some study in order to do this, right?
Right.
I think the difference and differentiation between this is that we're saying, well, these shouldn't be, shoehorned into like a research study if it's not really, right? So this is
Right.
new for Sunnybrook. It's mostly new, I would say, in healthcare institutions in Canada. There are some isolated cases where they are de-identified data, sharing data for innovation, and they're doing great work. There are some cases where they have like trusted research environments where they're doing this. It's very, very isolated and very not very common at all, which I think is, and I
Mhm.
think I mentioned this before the call, which is why there's so much interest in figuring out how to do this responsibly, and why everybody needs to talk about it and understand what processes are being put in place, because we need to up that comfort level, I think, from institutions in order to engage in this.
Right. And you did mention that I think Kai Hai or who was it had some information on
They,
that.
they had the stewardship piece. Oh, and
Okay.
the value thing. I'll just quickly say nobody has an answer to
Yes.
this in Canada yet, but again, like this
Okay.
just really depends on the opportunity. If you are supporting a researcher that's going to develop a technology that's going to be a startup company, take that into account versus like some kind of M&E that's developing some future technology. You don't want to gouge people for their data if it's going to benefit Canadian healthcare, right?
Right. Right.
This is a topic, like the valuation of data is a topic we're very aware of. I'm hoping to come up with something this year that I can share with people.
You're going to need data to be able to share the value
Yeah,
of
I need
data.
people to tell me what they're doing, right? We need to have these
Right.
conversations.
Right. And that's why you want to know if people are taking part in the INOVAIT program. Um, well, Phil, oh my goodness, there's a lot more we could talk about. We've gone over time, everyone. It's been such an informational session. We are having your colleague, I believe his name is Raphael. Raphael,
Yeah,
one of the
Raphael,
director
he's
of
the
business
director. Yeah,
development.
yeah,
He will be
and an
joining
innovator.
us at
Yeah.
our yes, at INOVAIT. So he'll be joining us at our upcoming conference, like we mentioned. It's the National Healthcare Business Development Conference on May 7th to 8th this year in Toronto, or you can join us virtually. Philip, thank you so much for your time and for
You're
sharing
very welcome.
all
I,
that
I tried to jam
knowledge.
in a lot of information in there in what seemed like a short period of time, but I'm happy to follow up with
Yep.
people afterwards.
Please do, everyone, if you'd like to connect with Philip. I'm sure you'd be more than happy to have them
Absolutely.
reach out on LinkedIn, I'd
Yeah.
assume, if they wanted to get this started at their organizations. Well, that's it, everybody. Have a lovely day. The recording will be sent in an email as well as a copy of the presentation slides.
All
Have an
right.
amazing day, everyone. We're going to
Thanks, everybody. Thank you.